Greetings everyone, Dr. Koehler again with another training video for you, but first a joke, okay? They said this is like a fireside chat, so no doctor's coat, fireside chat tonight with this, but okay, my friend here, Bill, is going to be part of the joke, okay? So, knock knock.
Who's there?
HIPAA.
HIPAA who?
I can't tell you. Sorry. Hey, you know, if Dr. Buzzard can crack jokes, I can crack jokes too. Okay, so not as good as his, but I gave it a good try. Anyway, so on a more serious note, occupational medicine. The videos that I produce are for training for occupational medicine, which is a very large segment of our business. Approximately almost 50% of our revenue is derived from occupational medicine, so it's very important. Obviously, OcMed is a challenge. It's difficult. If it wasn't difficult, everybody would do it. But because it's so difficult, we can rise above that and we can be successful and gain market share by being experts at OcMed. So we are experts in OcMed, and we are promoted that way, marketed that way, and highly respected where we serve for occupational medicine ability. This video is case closure. And I realize that most cases close easily. You see them 2, 3, 4 times, they're released, they're getting better, everything goes well. Because as you know, injuries follow a progression of healing. That you have tissue injury, there's cytokines, macrophages, other microscopic level immunological responses to that, which creates inflammation, so you have pain and swelling. Then the body then starts adding collagen in terms of scar and support and that kind of thing to the tissue, then it matures. So soft tissue healing follows progression just like fractures. We already know how fractures heal. A very predictable progression. We can x-ray it, which is an advantage, but soft tissue has the same thing. So soft tissue injuries, they should have pain right away. They could even have more pain the next day possibly, but then they should be getting better each recheck. So as far as our treatment goes, that we would expect that progression. If that progression doesn't occur, as in my other videos where I've talked about this, we upgrade our imaging. Someone's wrist is still painful and swollen, it's not getting better, they need an MRI for TFCC tear or scapholunate ligament tear or occult scaphoid fracture, that type of thing. So same with the knee, same with the back. We upgrade our imaging when the patient's clinical progress is not following the expected norm. The other option is that they could be engaging in secondary gain, inappropriate injury behavior, which relates to the discernment video I produced before, which you've seen, and talks about how to discern when the pain they're still saying that they have, because pain is subjective. As yet, there's no painometer, unfortunately. It's subjective, so we have to verify that with physical findings, a thorough physical examination, imaging studies, and our level of discernment and clinical acumen to decide what do we do next. So I published orthopedic treatment protocols in Dr. Koehler's Quick Reference Manual, East State Street, where I'm at now. This is their book. And so the second tab, or third tab here, is orthopedic treatment protocols. And this is cookbook, very easy. You can see in here lacerations, shoulder injuries, head injuries, cervical spine, chest injury, elbow, back, all this, like 3 or 4 visits worth, so that this is the expected norm. It talks about when to have, medications, prednisone, physical therapy, injections, MRI scanning, those kind of things are all laid out here for you very easily. So you need to refer to that when you have a case that you want to know, okay, what do I do next? Visit number 2, and I want to learn. So this enables you to become very familiar with how these cases should go, because I've been around a while and have some experience, and this is what I have set up as far as guidelines and protocols. So you can always ask a question, hey, Dr. Koehler, or call one of the regional medical directors or Dr. Buzzard and say, hey, I'm on visit 2 and I'm not sure what to do here, or I'm on visit 3, 4, that kind of thing. So 95% of all of our cases are easy and follow these outlines, very simple cases. But every now and then you will have cases, not every now and then, but actually since you're seeing so many patients, that probably every week you're going to have a few patients that are chronic cases or persistent cases. And these are the ones that this video is about, because those are the ones that create havoc with the companies. Just got a complaint this week on a case that ran for 9 months and was finally sent to orthopedics. The company didn't like the orthopedic surgery group, and the case kind of blew up. So typical problems with too many different doctors. No one took responsibility for the case and kept the case. The patient might have been non-compliant, which is another issue. So for purposes of this video, I want to make it really clear that when you have a case that's beyond 4 weeks and not getting better, that's red flags and sirens, okay? Red flags and sirens. That you're at that point, you're on the 5th visit, not getting better. You've applied discernment, you've done the studies, upgraded imaging, those things have all been done. Prednisone, injections, all that's been done. We're with the patient, 5th visit, not getting better, still having 7 out of 10 pain, maybe a little bit of Waddell's, that kind of stuff. When those red flags and sirens go off, that's time to call Regional Medical Director, Dr. Buzzard, or myself, and we got to work through this. Or a senior physician that you work with is perfectly fine too. But those of you that are senior physicians, you need to put forth the effort to really discern the case with whoever's calling you so that we figure out how to deal with this chronic case. So, first of all, we have to check all the boxes with, okay, has everything been done? Do we believe we have the right diagnosis? Because you don't want to be at the end where you're going to close out a case, explain to a patient that their pain is going to improve over time, there's nothing further we can offer them, those kind of things, and end up missing a Lisfranc fracture in their foot. Like, your x-ray's negative, no MRI done, x-ray negative, 2 Lisfranc fractures we've missed. You should look up Lisfranc fracture if you don't know what that is. That's a fracture dislocation of the tarsometatarsal joint of the foot. Severe injury, and these people have severe pain. We can't just say, your pain's going to go away if we've missed the diagnosis. Okay, so there is a point which we're going to tell the patient there's nothing further we can do, but we absolutely have to make sure we have the right diagnosis. So have, repeat x-rays, MRI scan in your hand if the patient continues to complain of pain and they don't have flagrant Waddell's or fraud, that, obviously we don't keep studying someone who has a paucity of physical findings and still has to have pain along with all the Waddell's test positive. So that's how you deal with this. The first thing is chronic case, everything's been done, diagnosis is right, now what do we do? Okay, so at that point, obviously, again, thorough physical examination, thorough assessment, apply the discernment principles. Then we might have to say to the patient, okay, Joe, or whoever it might be, we've done physical therapy, you've had anti-inflammatory medication including prednisone, you've had splinting, bracing, light duty, we've graduated you back now to full duty, and I understand you still have 2 to 3 out of 10 pain, but we've done everything we can for you. There's nothing further that we can do that will reduce your pain any quicker than it will on its own. So we have no reason to continue to see you here. We've got you this far. It's going to be good. It's going to work out fine. So at that point, you become a cheerleader in a sense, where you need to have positive energy about it. It's going to be okay. The normal progress and pathophysiology of soft tissue injuries, they get better over time. So we fully anticipate that your shoulder pain, knee pain, ankle pain, back pain is going to get better over time. You can wear this brace, you take over-the-counter medication, and that type of thing. So at that point, that we need to if we have to close out the case, we close out the case. We cannot be party to these 9-month cases, 6-month, 9-month. We can't be party to that. And unfortunately, we are the closers of last resort. Okay, in the entire ecosystem of occupational medicine, the occupational medicine clinic is the closer. There's no other closer out there. FCEs are not closer. In fact, FCEs are unreliable. Those are not, functional capacity assessment. No, they are a functional tolerance assessment. That's simply tolerance, meaning the patient does what they can tolerate, and if they decide they don't want to tolerate 40 pounds, 50 pounds, they won't do it, and the FCE will report that and then tell them to work U.S. Department of Labor low-level work, you know. So FCEs, no, they're not a tool. We don't use them. They don't help anything. Okay, we don't refer to IMEs because we are the IME. Okay, we are the experts. If the company wants to order up an IME to corroborate our findings and our recommendations, that's great. They can do that. That's the purview of the insurance carriers, adjudicators, TPAs, and companies. It's not our job to order IMEs. You could have a conversation with the company and say, we're closing out the case today. They're at maximum medical improvement, MMI, and you could say if you want to order a IME to corroborate our findings, that's fine, and leave it at that. But I've seen cases where it's like 3 visits and someone mentions and getting an IME. That's punting. So we don't punt FCEs. We don't punt IMEs. We don't punt to specialists. We only use specialists when they need to operate on a diagnosed lesion, or we want a 1-visit consult where they can see the patient, render their opinion, and come back to us for treatment. If during a 1-visit consult they diagnose something we missed and they need care from that doctor, that's fine. That's good. But other than that, we do not use specialists to close cases. We do not use specialists to deal with chronic pain patients. We do not use specialists to do our work, okay? I know that's difficult, and I know that that's hard, but all is not lost, okay? We have spectacular regional medical directors, the great Dr. Wolin, the great Dr. Etner, the great Dr. Zander, the great Dr. Gregus, the great Dr. Apostolopoulos, and the great Dr. Buzzard, and myself. We're there. We can be your IME doc if you want. You can call us and say, I need an IME, or I need a consult, or you can refer to the senior physician at your clinic. You can refer to the regional medical director to see the patient. You can have reach out to Dr. Connor, for example, at Bolingbrook and Glendale Heights is available as a senior physician for consult. So in-house, okay? We keep it in-house and we close it. We don't use other entities out there to do our work for us. We cannot get into that. I get flamegrams from the companies about punting. They just go crazy, just go nuts, because they depend on us for objectivity. They depend on us for diligence. They depend on us to say the truth, call it a day. We don't participate in chronic, ongoing rubber stamping care. We just rubber stamp. And if you're seeing someone else's patient, determine, and this has been in the other videos too, is this somebody else's patient that they stumbled in and they missed an appointment and they came to see you? Please get them back to that doctor so we have continuity. If you see that it's the second visit, so you're number 2, then you should keep that case for continuity's sake, unless the patient says they want to go back to the original provider. But don't say, well, why don't you go back to see that? Or don't suggest that you want to sort of like ditch their case like a hot potato. Engage them. Use the first person pronoun about yourself. I would like to see you back. Can you make it back next Tuesday? I'll be here from 8 a.m. until 12 noon. Can you make it during that time? And make sure that they agree and concur that they're willing to come during that time. So it's important to maintain continuity so that we don't have 6 months of a case and 6 different doctors and PAs and nurse practitioners seeing the patient. So we can't do that. So, okay, but we are the quintessential case closers. We have to be able to do that. Okay, so, all right, so again, the guidelines are available. This will help guide you, follow the case, move the case along, reach out for help if you get stuck. And always feel free to give us a call. One of the chronic cases we had recently, the provider who was seeing the patient like at the 9-month point said that the provider did not want to call the regional medical director because they did not want to bother the regional medical director, instead referred to ortho, and the company went nuts. So please keep it in-house, work with your regionals. They want to receive those calls in those cases because we have the repair work to do, okay? So we'd rather have the phone calls at the time and assist you and help you out. We'll make it easy for you. We'll ask you questions and such. You'll learn as you go. But we really need you to reach out and give us a call so that we can take care of it with you. Also, that the outside referrals I talked about, that we would only do an outside referral if they need surgery and if we need a once-visit consult. I would suggest, especially if you're new at PIC, that you would call a regional to talk about, or a senior physician to talk about a referral to ortho or a one-visit consult, just so you're on the same page. And obviously, in the other videos, we talked about no referrals out of cases without getting concurrence from a senior physician or regional. Also, as a general matter of how OCMED is done, we don't refer to chiropractors. I don't have anything against chiropractors per se, but the case management folks, the companies go ballistic, crazy. So we don't refer any OCMED patients to chiropractic. If the patient wants to choose a chiropractor, then they can choose, and please make sure you document patient chose to see chiropractor Jones on their own accord. Anytime they don't follow our guides of our referral pattern, you need to put in there, patient decided to see Hinsdale Ortho, patient decided to see Parkview Ortho. Put it in there. They decided, they went on their own, they made that own decision. It has to be very clear, because it can't look like those doctors are in the chain of referral from us. The companies will go crazy because they hold us accountable for everything the specialist does. And if the specialist takes them off work, racks up $30,000 of PT, it's on us. Other specialties besides chiropractic, we don't refer to podiatry. Again, blackballed by the carriers and such. We don't refer to pain management as pain management. We refer for an epidural. We call it epidural. We never, ever refer for pain management because, again, the companies will go crazy. So we don't refer to physiatry either because we can do anything a physiatrist can do. So please keep it within the quick reference binder. It talks about the quick reference referral sheet is right here, which specialist that we use and refer to for occupational medicine patients is in the quick reference binder at all clinics. So please stay within that guideline. Don't bounce out of it unless you talk to one of our senior physicians, regional medical directors, and get clearance to do that. Okay, to summarize then, when we close out a case, we close out a case because we're done with care, that there's nothing further we can do. It's, pushing on a rope. There's nothing left. We've done everything. Their pain is down 2 to 3 or 0, case closure. Okay. We could release them for fraudulent behavior, inappropriate injury behavior, Waddell's from the discernment video. We could put in there, we have nothing further to offer this patient. They're non-cooperative, engaging in inappropriate injury behavior. If you ever want me to write up that script, I can do that. I've done that. I'll just send the email of the closure script in an email to you, and you can just type that into the chart. So that's available. I'll just write the script for you. Non-compliance. If they keep missing appointments, we can close the case, just carte blanche for non-compliance. Fully released from our care for this problem at MMI due to non-compliance. Abusive behavior, we close the case out. If any patient is at any point engaging in what you feel to be abusive behavior towards you, you can close the case or refer it to someone else. Ask the patient to leave immediately, and if they won't leave, you can say, I'm dialing 911 right now. So you can close a case out for that type of thing. So those would be the reasons for closing out a case. But we do want to get as many closed as we can, as efficiently as we can. We did a study, about 2,700 patients, and we're about 3.2 visits per case, which is good. And so that's roughly 3.5 weeks. We recheck patients generally a week or less. Try to avoid 10-day rechecks because that drags the case out too long, especially if they have restrictions. Don't do a 10-day recheck. Bring them back. They'd rather see 3, 5, 7-day type rechecks, and the more restricted they are, the sooner you recheck them back. So keep that in mind. Takeaway message from this, again, if you're at 4 weeks, 5 weeks, the patient's not getting better, still complaining of pain, reach out and get help. That's what I'm saying. So, and if, let's say, you're at the 6 weeks and this still, whoever saw it before at the 5 weeks didn't take care of it, you definitely have to take care of it. So I really want cases closed out 6 weeks max to close out these cases and get them taken care of. So, and when you close a case, the definition would be fully released from our care for this problem at MMI. That is enough. If you want to put in without residual disability or impairment, that's fine too. But MMI is the trade language maximum medical improvement. So case is closed. Don't put in the record ever, you can come back here if it gets worse again, because that's our tendency. Our tendency, they still have 2 to 3 out of 10 pain. We're releasing them. We're thinking, we're pushing them a little bit. Let's just say, hey, you can come back again if it gets worse. Don't say that, okay? But you can say, if there's a recurrence, you can talk to your company, and if they deem it to be referred back, that they can refer you back to us with a new authorization. We can take care of you then. So don't leave any caveats, because that's not case closure. If there's any kind of caveat that opens the door for them to come back, then that case is not closed. It has to be fully released from our care for this problem at MMI. That is the language for a full release. So appreciate your patience in all this. Appreciate your hard work. This does take some effort on this, but once you get used to it and see enough patients, it gets to be easy. OCMED can be fun, getting patients better, and taking care of any case that comes in. So thank you very much for your time this evening. Thanks for your care. We'll talk to you later. Bye.